Stage 3? No, maybe stage 2? Or is this grade C? No, this is not making sense. I need help.
Come in, Steve. Dr. Malik, I'm really struggling with staging and grading. I memorize them, but when I see a real case, I get confused. I keep mixing them up. Sometimes I don't know if I should focus on the stage first or the grade first. And when I look at a case, I don't know where to begin. That's because you're starting with the label. Don't memorize the label. Read the disease.
Let's make it simple. Stage tells you how much damage is already there and how complex the case has become. So don't start by guessing the stage. Start by asking what the disease has already done.
If the damage is limited and the case is still straightforward, the stage stays lower. But if the destruction is destruction greater, or the case becomes harder to manage, the stage becomes higher. Let me ask you something. If an earthquake hit a neighborhood and an engineer told you there's damage, would that be enough?
No, I'd want to know how much damage there is, how serious it is.
Exactly. That's what staging report in periodontics tells you is how much damage is already there and how complex the case has become. Dangel in the building as a building. Think of every tooth as a building. The bone, that's the foundation. That's a foundation. Stage 1, hairline cracks. Cal 1 to 2 millimeters. The building is still standing. Catch it early and it is easier to save. Stage 2, CL, the walls are cracking. CL 3 to 4 millimeters. Still standing, but now you need to act. Look at this one. Stage 3. The structure is still standing, but the foundation is failing. At this stage, you may see pockets of 5 millimeters or more, trauma attachment loss, vertical defection involvement, due and sometimes even tooth hermaitis. This is no longer a simple case. It needs serious intervention. Now look at this one. Stage 4. The structure is no longer stable. Function is breaking down. At this stage, teeth may drift, the bite may collapse, and chewing may be compromised. This is no longer just about treating periodontitis. Now you may need a whole team. Staging tells you how much damage is already there. But grading asks a different question. How fast did it happen?
So, same damage, different speed?
Exactly. Tell me something. 2 buildings, both have the same crack in the wall. Same size, same depth.
Are they the same problem? I mean, yeah.
What if I told you one crack took 20 years to form, the other took 6 months?
That's completely different.
That's grading. Same damage, totally different story. Look at the board. Grading tells you 2 things. How fast is this disease moving and what's driving it? Think of it like cars on a highway. That's your MIG, but you're staying to modifiers. Grade A, the Sunday driver. Slow progression. On the X-ray, the calculus everywhere, but the bone loss is surprisingly limited. This deposits are heavy, yet this minimal destruction is moving slowly. Grade B, normal traffic. Moderate progression. The destruction makes sense with what you see clinically. No major red flags, but you stay alert. Grade C, the one running red lights. Rapid progression. Bone loss is far beyond what the local factors explain. A young patient, minimal plaque, serious destruction. Something else is fueling this disease. And else you're for Foptins.
How do you actually measure the speed?
Best way, look at the percentage of bone loss on the effects ray at the most affected site and divide it by the patient's age.
And the result, as we can see on the board, helps us estimate the grade.
That simple?
That's your starting point. But then you still need to look for modifiers. You diagnose someone as grade B, moderate, fine. Then you notice something, smoker, a pack a day.
Does that change it?
Immediately, that pushes the case to grade to C. Smoking exacerbates bone loss. It masks bleeding and hides inflammation. So by the time you see the damage, it is often worse than it looks.
What else?
Diabetes. Uncontrolled diabetes, HbA1c over 7%. Grade C. The hyperglycemic environment breaks tissue down faster and impairs healing. You treat the perio, but you cannot ignore the systemic picture.
So the grade can change?
And that's the beautiful part. Unlike stage, which reflects damage that has already happened, if the grade can improve. If they reassess, the disease controls their blood sugar, the modifier slows down.
So stage is permanent, but grade is dynamic.
Exactly. Now you're thinking like a periodontist. 2 patients walked into my clinic this week. Same complaint, my gums are bad. Same words, completely different stories. Let's work through them together.
All right, what do we have?
What do we have?
Male patient, 52 years old. His chief concern is my teeth feel loose. He is a non-smoker with no systemic conditions. Oral hygiene is poor with heavy calculus deposits.
Understood. Let's review his chart.
Okay, pockets are over 6 millimeters. Clinical attachment loss is over 5 millimeters. Bone loss extends beyond the third. There is class 2 furcation involvement and tooth loss due to periodontitis. So what stage?
That's stage 3. Wait, he lost 3 teeth. Is it still stage 3?
Good question. How many teeth lost due to periodontitis would push the case to stage 4?
5 or more. He lost 3 teeth, so yes, stage 3.
Good. Now let's determine in grade. His age is 52 and the radiograph bone loss is roughly 45%.
So 45 divided by 52, that gives us about 0.86.
Between twos, that place him.
And where does that 125 and 1.0? So that's grade B.
Any grade modifiers?
He is a non-smoker with no cystostom disease, so no modiagnosers.
Good.
Generalized stage 3, grade B periodontitis.
Exactly.
Clean and straightforward. The amount of destructualists, matches, poor local factors, it is an age. The story makes sense. Female patient, 28 years old. Chief complaint, my dentist told me I have gum disease. Smoker, 15 cigarettes per day. Type 2 diabetic, HbA1c is 9.
Same question. What do we see?
Probing depths are 5 to 7 millimeters. Clinical attachment loss is around 5 millimeters on multiple posterior teeth.
And no KLR allowed 5 millimeters, pockets up to 7 perimeters. Bone loss reaches the middle third of root.
Stage?
Stage 3.
Good. Now grade. She is 28 years old and the bone loss is around 30%.
30 divided by 28, that is about 1.07. So it is of grade C already, so if it's before modifiers.
But when we look at her mouth, what are your notes?
Minimal calculus, relatively clean.
Exactly. Minimal local factors, but major destruction. The damage does not match the deposits. That pattern strongly points to grade C.
She smoked 15 cigarettes per day. That is 15 or more cigarettes per day, which is a grade C modifier, another grades percent.
And then her H is 9%. A-controlled diabetes is HB1C over 7C modifier.
So everything is pointing in the same direction.
And that is the lesson. Sometimes the grade surprises you. A 28-year-old with a relatively clean mouth can be easy to underestimate. But the numbers do not lie.
Full diagnosis? Generalized stage 3 CC periodontitis.
And what is your priority before you even touch the periodontal treatment?
The diabetes. We need to get the HB1C under control.
Now you are thinking like a periodontist.
3 weeks ago, I thought perio was just scaling.
And now?
Now every x-ray tells a story.
Stage tells the damage. Grade tells the danger. But never forget, the patient is the story.